All right, today we've got a legend in the house, someone who spent his career standing at the crossroads of science, clinical mastery, and military precision. Dr. Gail Deyle is the clinician-scientist who doesn't just talk evidence, he generates it. He's mentored generations of residents and fellows, pushed PT diagnostic competency forward, and published clinical trials that have shaped how we treat chronic musculoskeletal conditions. If you care about advanced clinical reasoning, fellowship training, or the future of PT's role in global health, buckle up. This is going to be a good one. Let's get into it. Gail, welcome back to the show.
Well, thank you very much for allowing me to sit here with you today.
Last time we recorded, we were in person. We were at the AMT conference in Reno. So my first question is, did you make it out of there with all your money, or did you leave some in the machines or on the tables?
No, I escaped there relatively unscathed. So
my problem was I was up $25 in the first day and then down $125. That's how the law of averages gets you.
Yes. No, I didn't go through that. So
smart. That's because you're smarter than me. That's why you're the guest and I'm just the silly host. All right, so let's start with this. You've mentored physical therapists across every level of training, but I want to know this. What's one trait you see in the clinicians who really take off after fellowship? Is there one trait or many that you probably can see in people, and when you see it, you know this person's going to take off?
Well, I think it is the clinician that realizes patients are complicated, and with that there comes a certain humility you have to think that no matter how much effort I put into this or how hard I've worked, I'm still relatively unprepared to take care of the complexities that I'm likely to encounter on a day-to-day basis. And I think that the more hungry that either residents or fellows when they go into training are, the more they really want to be able to offer their patients that's uniquely skillful. They bloom in the training. And their trajectory for their post-training growth is really more sharply elevated, and they continue on that pathway.
Yeah, and you've been doing this for a long time. Is it fun, I imagine, to run into people you mentored 5, 10, 15 years ago and kind of listen to the stories of where they've gone since then?
Oh yes, and at times it's almost like the mentoring role has changed. I can go to them and talk to them or ask them questions, and they've been able to specialize in things that I have not, or they've gained experiences that I don't have, and so it just kind of flips the mentor-mentee thing. But that's one of the most rewarding things, I think, of someone who has been in my position and had some opportunity to work with and help the growth of some of these clinicians.
Yeah. Well, let me flip it then. You've worked as a mentor with mentees. Not everybody probably should be a mentor. I just mean, like, what makes a good mentor? How did you know that mentoring? It's one thing to be a good clinician, but I'm guessing vastly different to be a mentor to someone else to do that.
Yeah, I think you have to be willing to be a role model and to be exemplary, and there's times when you have to break down what you're doing so it's consumable. Sure. so they can see exactly what that is, and then there's just times when the ethics of certain situations will challenge a mentor, and you have to be willing to show your cards, and I think you want to make sure you stay on the high ground, and so that the mentee can see the complexity of the decisions you had to make, how you got there, and why you did what you did.
Now, Gail, you're a strong advocate for physical therapists as frontline diagnosticians. Is there a story that you've got, a moment when a PT's diagnostic skill really changed a patient's medical path? Anything come to mind?
Well, I guess I've seen it so many times where we've had Physical therapists, take patients that have been sent to us and they've been through a fair medical process, and their diagnosis is such that they do not belong in physical therapy, and it's hard for one to stand out. But these things, ranging from trainees being in a line with chest pain and they were having myocardial infarction, to tumors growing in young people's long bones, to infections and leukemia, and it just, the list keeps on and on. But I think physical therapists do really well at being able to interview their patients, particularly if they've had some advanced clinical training, residency and fellowship level training, and they can quickly determine, this just does not seem to be appropriate
Sure.
For physical therapy. So it's, I have some teaching examples sometimes that I use, but it happens frequently enough that it's really not one unique thing. But it's almost like, if you had oversight to all the therapists that work in most of the settings that I've been in, it's probably every other day somebody pulls some patient out of there that doesn't belong in that clinic.
That's great. You mentioned advanced clinical reasoning. When you think about that, when you think about advanced clinical reasoning, what's the biggest unlock that most clinicians miss early in their careers? Is there something holding them back? You mentioned a minute ago, really being able to understand that the patients are complex. That's got to be one of those unlocks. Is there anything else?
Well, I think for someone like me, who I was very internal with my
Okay.
processes, and I think that there was a lot going on, and I think I'd had lots of experience, and there was things that I could just kind of tell what it was when you see it walk in the door. But until you bring your reasoning out and look at it and examine it and probably have somebody help you with that, you're not going to be as clean and as efficient as you could be. And so, if you take what's implicit and make it explicit and get it out where it can be seen, and where you're making mistakes, or you're jumping to certain things, or you're not exactly asking the right thing, or you've missed opportunities. Those are the kinds of things that will elude someone that probably hasn't been through some formal training in how to get better at clinical reasoning.
It sounds like it's the physical therapy equivalent of you got to show your work, not just your
Yes,
answer in math class.
that's pretty much it. And there's a certain willingness. I mean, it's a little invasive to have
Sure.
someone come into your space and say, well, okay, but there was some things you could have done better here. And and your thoughts are personal, and so on and so forth. So it really, there's a willingness on the mentor's side to get a little bit of the mentee on them, and and to be a little invasive, and then and then mentee has to be accepting of that. And
Yeah.
if you get defensive, then that's where growth stops.
Yeah. I imagine setting good expectations early on in that process of, I'm going to push you, but there's a reason to it. It's not me trying to step on toes or make you defensive. There's a method to it. So I imagine setting good expectations is probably important.
Yes. Yeah, I think good communication both ways there is very helpful.
Yeah. You've said that physical therapists are an untapped contributor to world health. What's one global health problem you think PTs are really uniquely positioned to help and impact?
Oh, I think, just musculoskeletal health, worldwide, would really benefit from unfettered access to physical therapists, and their low risk, high benefit strategies, things that don't push patients down the pipeline of advanced imaging and invasive things, whether it's diagnostic invasive things or whether it's treatment invasive things, that there's so much that physical therapy would have to offer. And, and I think at times we have this wrong with third party payers, thinking, well, we'll save some money and we won't pay for physical therapy, and really it's the opposite. You need to open your portals up and get these patients, out of probably the whole medicalized pipeline and get them into someone that can help these patients be more active and be healthier, and and have things that some strategies that are lower risk and less costly.
All right, Gail, we're going to play red light, green light here. For all the clinicians listening, what's one habit you think they should stop doing tomorrow and one habit they should start? What's a red light and a green light if they want to become sharper, safer, more effective? What do you typically suggest?
I would, if possible, I would try to make your administrative processes as efficient as you can.
Yeah.
And spend more time with your patient. That would be my big green light. Get your hands on them, get your interaction to be more intensive. And, I think it's very hard to replace a highly qualified and trained physical therapist in most of our clinical settings. And so the intensity of the interaction between the physical therapist and the patient is, I think, where the true value is. So that's definitely green light.
All right. Excellent. Gail, this is outstanding. Nice little short burst of insight. You spent a career proving what skilled, well-trained physical therapists can do, not just for patients, but for the profession and for global health. Love your mix of curiosity, rigor, mentorship, exactly what keeps pushing together physical therapy. So thanks for doing what you do here with AOMT and for the profession.
Well, thank you very much, Jimmy, for having me. And I would add one thing. Colleague sent something to me a couple of days ago and posted on Baylor, where I have a faculty appointment as a full professor. They've got my name and profile, and that I am in the top 2% of cited researchers in my field, which is truly amazing for me, just to think I'm a grassroots guy.
Wow.
I worked with colleagues. We took clinical questions that were relevant, and we did studies to try to get answers to those questions, and we pushed them out into quality journals. And just to see that, to be in the top 2% of cited researchers,
wow,
is amazing.
That is amazing. What led you to tackle on big questions like that? Doing research is not, none of those are small questions. It's got to be big. What sort of made you feel like, yeah, I can do this and it's worthy, because the effort is large?
Well, I think it is. In some of these trials, it's about equivalent to raising a child. But
Yeah.
when you take something from concept to publication, it may take a few years. And I think it's just being hungry as a clinician, and you have these questions, and the literature, doesn't provide the answer to it. You think you see this, but you don't know. And so now it's a matter of putting it to the rigor of a clinical trial. And I think clinicians and those that indeed have some advanced training and some advanced education are in a great position to design clinical trials. And, at times you may want to consult with people that are in full-time research positions and so forth. It isn't like you're out there all by yourself. But, I think a group of motivated clinicians, working, and, and most of our research was unfunded, not connected to any big grants or anything like that. But so I think it points to the power of what someone who's motivated, to get more information, to be able to use it in clinical practice, what you can be able to accomplish.
Yeah. All right. I said last question before, but I'm going to say last question again. What would you say to that clinician out there? They're not a researcher. I'm using air quotes. They're not a researcher. But what would you say to them of why it will help their career and, of course, big picture, help the profession of taking on either a large or a small research project? Because we need those clinician researchers.
You do, and I think what they can really add. One, you have the patients, so you have the subjects for any clinical trial, and you may have the question. And there's nothing wrong with collaborating with a research center or an educational program of one sort or another, whether that's at the entry level or that's a graduate level program. And you might be able to look at their research question that they're about ready to embark on and say, I'd do that a little differently. I don't think that question's so relevant. It's just from what I'm seeing, if we would tweak this or do this a little bit differently,
Yeah.
that might be a much better question. Maybe it would yield you something that clinicians need in order to be able to go in and do business on a day-to-day basis. And I think that's what you would have the most to add. And if you think, well, in the statistical analysis, or maybe, what is the most rigorous design or something like that, yeah, there's plenty of room for collaboration with those things if you feel like that's not exactly your skill set.
Yeah, and we need that, right? The researcher and the clinician, they just bring different things to the table. I imagine it's probably better than the sum of their parts.
Oh, yes.
Love that. All right, I promised you last question. I got it. Gail, appreciate some insight. We'll love to have you back on the show sometime soon.
All right. Thank you very much.